Okay, for the first speaker, it's Dr. Shuaib Abdullah, who's our Director of Non-Invasive Testing at the VA North Texas Healthcare Center, and an assistant professor at UT Southwestern. And Dr. Abdullah will be discussing topics relating to some of the potential complications following TAVR. Dr. Abdullah?
Okay, thank you, Dr. Garcia and Dr. Velakis for helping set up the computer. So I'm going to do a case presentation about a recent TAVR case we did. So we had an 84-year-old man who's past history of hypertension, diabetes, coronary disease, and he underwent transfemoral TAVR. Post-procedure, TE images showed the following. Well, they showed more than that, but okay. So basically, the transgastric views showed a mild amount of paravalvular aortic regurgitation. And then if you look at the mid-esophageal views, they showed that it was coming at the origin of, basically there seemed to be a small paravalvular leak next to the right coronary cusp. So what is the significance of paravalvular aortic regurgitation post-TAVR? So unless you were sleeping during Dr. Bauer's excellent talk, you guys probably have a pretty good idea what the significance is. But I'm going to delve on it a little bit more. So as Dr. Bowers talked about, the Partners A and B trials showed that in patients who are considered to be high risk for surgical AVR, TAVR is non-inferior to surgical AVR. And in patients who are considered to be non-operable candidates, TAVR is superior to medical therapy. So post-TAVR aortic paravalvular aortic regurgitation is actually very common after TAVR. The partner studies, approximately 80, in both partners A and B, approximately 80% of patients had at least mild AI. Now, if there's different estimates of how common moderate to severe AI are, because of different ways of measuring and no validated measures to actually quantify paravalvular AI. So, but if you look at a meta-analysis that looked at 3,500 patients, moderate to severe post-valvular AI is estimated to occur in about approximately 7 patients, or 7% of patients. So why is AI associated with poor prognosis? So if you were to understand that, you would look at the hemodynamic and pathophysiological changes that occur in AS and how AI may significantly impact them. So here, in this patient with severe AS, you can see that during systole, because your aortic orifice is significantly narrowed, the left ventricle needs to generate a significant amount of pressure gradient to sustain a cardiac output. So here, you see the left ventricular pressures will exceed often 200 millimeters of mercury. Now, once you put the valve in and you relieve the obstruction, you don't have that significant gradient anymore. You see in the post-TAVR image that your left ventricular systolic pressure is only 140. Now, what happens if you introduce severe AI into a patient who has concentric LVH from AS? So you have a large amount of blood that will go from the aorta back into the left ventricle, and because you have significant hypertrophy and a non-compliant left ventricle, you'll see a significant amount of increase in both left ventricular and diastolic pressure and left atrial pressures. Now, if this is extreme, you'll get a diminished cardiac output where you actually get cardiac shock. So that's one way severe AI can lead to poor prognosis in these patients. The second way is that even if you have moderate AI, where the left ventricle here in the bottom left diagram is able to handle your return of blood into left ventricle, and you still get a mild increase in acutely. You still get a mild increase in your diastolic pressures, both left ventricular diastolic pressure and left atrial pressure. However, over time, we have chronic moderate AI, you'll get left ventricular dilatation that's associated with poor prognosis. These pathological hemodynamic consequences can be translated to the poor outcomes seen in paravalvular leaks. So here, the incidence of paravalvular leak is a lot lower in surgical AVRs, but you can see here patients who have post-surgical AVR, but patients who have mild or no AI post surgery, which is the solid black line, have a significantly better prognosis than the dotted line, which is patients who have severe or moderate AI. So that change seems to occur both acutely and if you look at up to 20 years of outcome follow-up data. So again, as Dr. Bowers talked about, when the 2-year results of partner trial came out, it's moderate to severe AI again was associated with significantly worse prognosis. Here you can see the green line representing a moderate to severe prognosis. But what made news is the orange line, where you saw even mild amount of AI was associated with poor prognosis. So, and then again, different studies have reported different prognostic impact of having mild AI. This meta-analysis that looked at 45 of these studies showed that moderate to severe AI was associated with a 2 to 2.5 increased risk of mortality compared to no AI. Now, when they looked at mild AI, they did see a significant increased risk, but when they did sensitivity analysis where they took out some of these studies, they found that relationship wasn't significant anymore. So there's still a little bit of controversy whether mild aortic regurgitation, paravalvular regurgitation is associated with poor prognosis. So to understand why, to understand how we can minimize the risk of AI, to understand how we can minimize the risk of AI, we have to understand how TAVR differs from surgical AI. So as you know, when you do surgical AVR, you have you actually implant, the surgeon actually sews in the aortic valve into the annulus. When you have TAVR, you're relying on the stent of the valve to be well opposed to the wall of the annulus. So anything that causes the stent not to be opposed to the aortic annulus will lead to as a risk factor for causing AI. So valve undersizing will lead to significant AI, and significant calcification of the aortic cusp can also lead to significant AI, because once you're trying to expand the valve and crush the calcified leaflets, if there's a significant amount of calcification, that may prevent the apposition of the stent with the aortic annulus. And then finally, malpositioning, either lower than the valve or higher than lower than the true annulus or higher than the true annulus. A placement of the valve can cause significant AI because while the stent is not opposed to the aortic wall. So this this graph here describes why shows that valve sizing is very important. So here on the x-axis is different degrees of AI, and on the y-axis you have the transcatheter heart valve diameter minus the mean annular diameter. So the higher your transcatheter valve diameter, difference is compared to what the mean annular diameter is, the lower incidence of AI that seems. So based on this study and similar studies, it's recommended that your aortic valve be a few millimeters bigger than what your actual valvular size is. So your prosthetic valve size should be a few millimeters bigger than what your actually measured annular size is. And different groups have come up with different indices. The area cover index is 1 minus the annular area divided by the prosthesis area. And the lower values of the area cover index has been associated with worse AI. And then finally the cover index, which basically is the difference of the prosthetic diameter versus the T annulus diameter divided by prosthetic diameter. And 8 to 10%, it's recommended that 8 to 10%, this should be greater than 8 to 10% to decrease your risk of significant AI. So I've talked about the high incidence of paravalvular leak and the poor prognosis associated with it. So it becomes very important when you're sizing the valve to be able to obtain adequate size. So imaging becomes very important. Most of our imaging when we're looking at the heart is used doing two-dimensional echo, but for several reasons, two-dimensional echo is inadequate to image the size of the valve. So one reason is that your aortic annulus is not actually a distinct anatomical structure. Unlike, say, the mitral annulus, your aortic annulus is actually just simply a virtual plane where the anchor points of all three leaflets pass through. The other reason two-dimensional echo is very poor as far as determining what your actual valve size is that your aortic annulus is not a circular structure but more of an oval structure. So if you could, depending on where you cut the annulus, you could significantly underestimate the size of what your valve of your annulus. So that's why multi-detector CT has been proven to be very useful when you're trying to estimate what the valve of your annulus is. Here you're able to take multiple multi-planar reconstruction, and using specialized software where you have these orthogonal planes, you're able to determine what your come up with where you see all three of the valve cusps attached to the annulus. So here on this figure on the right, you could appreciate how the annulus is oval. And you could also see, so different people will estimate size based on different measurements. Some people will take the mean of the two diameters. Some people will take the area. Some people will take the perimeters. And based on that, come up with what size prosthesis to use. So, okay, this images work. So for several, because you are dealing with such a high-risk population, you may not be able to give contrast for CT. And also, you may want to monitor while intraoperatively what the valve looks like. In that case, three-dimensional TE has been shown to have very good results. So here you can see on the left, you can see the three leaflets that are calcified and stenotic. And then, similar to when we came up with a annulus size using CT, by looking at different planes, you were able to come up with a size for your annulus with a three-dimensional TE. So say you do have a significant paravalvular leak, what can you do to decrease the aortic regurgitation? So one thing that's been reported, especially using core valve, is using a snare catheter and repositioning a valve. Obviously, you have to worry about embolizing the valve. And the second thing that can be done is using balloon post-dilatation. So if you have a core valve, which when you initially deploy the valve, you're not using a balloon, you could use an adequate sized balloon. If you have the Edwards valve, which you already are using a balloon to deploy, you could add 1 or 2 cc's more of saline and to cause a better post-dilatation. Valves that are malpositioned, meaning that they're positioned either too high or too low, you could do a valve-in-valve implantation. And in patients who have significant paravalvular leak, percutaneous occluders using implants occluders have been shown, have been reported. So, conclusion, TAVR has been shown to lead to increased mortality in patients who have aortic stenosis who are not good candidates for surgical AVR. Paravalvular aortic regurgitation occurs commonly after TAVR, and the degree of regurgitation associated with prognosis. And proper sizing and imaging of the aortic annulus is essential to decrease the risk of paravalvular regurgitation post-TAVR.